Morning, guys. Sunday morning. I'm getting this out, trying to get it out early. Um, this chapter or the unit, whatever you want to call it, just kind of gives you a taste of what you guys will be working on next semester in mental health. Um, kind of touches on things but doesn't go very deep. All right. So, what is mental health? Mental health, you're able to be flexible. You take responsibility for your own actions. You guys can read these. Um, but it's the healthy way of coping with things. You can solve your problems. You can cope with your daily stressors. It basically is positive, healthy sense of self-esteem. So then that leads us to what is mental illness? Basically, it's the impaired, the unhealthy mental aspect, impaired ability to think, feel, make sound judgments, impaired ability to adapt to the changing environment, um, inability to form personal relationships. As we go through some of the illnesses, you'll kind of see these pieces pop up throughout. Um, and it's a difficulty in being able to cope with a person's reality. So as a nurse, what do we need to assess? Their appearance will tell us a lot. If they're well kept, showered and put together, generally we say that they're mentally healthy. If they're disheveled and not showered, not shaven, sometimes we look at this and say, oh yeah, they aren't able to how do I want to put it, uh, perform these tasks. We're going to watch their behaviors. How aware are they of reality? We're going to assess their thinking or what their thoughts are. A lot of mental illnesses obviously affect their thinking, but they also affect what they're thinking. Their memory, their speech, their mood, and their affect are a huge thing in mental health. A lot of times you'll hear the word flat affect. This just means they're basically no emotion. We're going to assess their judgment. Are they able to make decisions? And then we're going to see how they perceive everything going on. So there's a lot of stuff that goes in on a nursing assessment in mental health. It's totally different than what you guys are used to. You guys are used to doing the physical assessments, but there's a lot of different things that go into a mental health assessment. And you don't have to be on a mental health unit to be doing these assessments. You see them on the floor, you see them in the hospital, you see them in the clinic, you see them everywhere where you're taking care of people. Physical disorders. These can actually mimic mental health disorders. So they need to be ruled out, whether it's labs, CTs, MRIs, PET scans, because it can be anything from an electrolyte imbalance, so like say a very low sodium can cause confusion, hypothyroidism, infections like a UTI in the elderly, they really mess with a elderly person's cognition, dehydration, drug toxicity, and I'm not talking just the normal or what we think of as when the kid goes out and gets really high, and it can actually be some of these drugs that the elderly are taking and they're taking wrong. Tumors or lesions. I have a friend who is actually hospice care right now. He was diagnosed, let me do the math here, when I was probably 23, so 15 years ago. He maybe it was even a little bit longer. But he was diagnosed with bipolar. He was in the psych unit. He was put on meds. So they just fully believe that he has had bipolar. Well, how many years ago? 5 years ago? 4 or 5 years ago, he had his first seizure. They took him in and found a softball-sized tumor on his brain. And now looking back, they're feeling that this tumor actually caused the bipolar symptoms, because obviously there's nothing concrete diagnosing mental illnesses, but they figured that the tumor actually caused the bipolar symptoms and why he was diagnosed with bipolar. So then the family looks back and says, oh, well, maybe if we would have been diagnosed sooner, it wouldn't have grown as much as it did, and it wouldn't have gotten to this point. But sad story. He's got 4 kids. Yeah. So always wonder, or always think about the physical aspects of it if there's no other history. Coping skills. Let me see what's recording. Oh, we gotta go into all those. We want our patients to have effective coping skills, because that's how they adapt to everyday stressors. So you guys have heard a little bit of anxiety, a little bit of stress can always be good. It's what drives us. If we're not stressed out or worried about something, we don't have that drive to do it. Sometimes it's also called the fight or flight mechanism, where you fight and you do it, or you flight and run away. And it just depends on how frequent a person uses it to how much is effective. So that leads us into ineffective coping skills. And I'll go through these, but then I'm also going to show you guys a video. I think I still have it up. I hope I still have it up. The denial, obviously, that is one that we deal with all the time. It's basically the person is unconsciously not seeing the reality. They're not purposely lying, but they're just in their brain they are denying it. They're saying it never happened. You'll see this in maybe a person who a friend of theirs passes away, and they're going to deny it, and they're going to say, yep, I'll see him tomorrow at work, or I'll see him tomorrow when we go out. But they're basically denying that whatever it was actually happened. Repression, this is just where they're repressing the event. They're burying it, or they're forgetting it because it's stressful and it's traumatic to them, so they're just repressing it. So maybe this is the young lady who was raped, and it was such a traumatic and stressful event for her, she's forgetting it ever even happened. Rationalization, they're just trying to figure out an excuse to cover up something stressful. You can use this one of, I didn't do my homework last night because the dog ate my computer. They're just trying to find a logical excuse as to why they didn't do an event, or why there was an event. Compensation, I have a hard time explaining this one. They're making up for an inadequate trait that they feel inadequate by developing a wanted trait. So if a person feels that they are not pretty enough, they may develop or they may work on doing makeup very well, because maybe they feel that if they have a makeup on, they are pretty, and it's kind of a wanted thing. Reaction formation. This is the same, kind of the same as compensation, but the person develops the opposite trait. I have a video that I'll show that actually shows this. It's a person meeting her boyfriend's ex, and she is sitting there saying, I'm not gonna like her, and then when the ex comes in, she's like, hi, how are you? And hugging and whatever, but it really kind of puts this one into perspective. Regression. This is when our patients are going to return to an earlier stage, so it doesn't matter. It can happen to anybody. You've seen the little kids when something goes wrong, or maybe they get hospitalized. Maybe they're 5 and they haven't wet the bed in 2 years, but they regress because they're stressed out and back into wetting the bed. Projection. This is just basically putting one's own unacceptable, I should say, traits and projecting them onto someone else. So if I feel that vaccines are not needed, that would be like me looking at one of you guys and saying, yeah, we don't think that vaccines are needed anymore. Displacement or else transference. This is basically I'm transferring my anger to a person that I feel is less powerful. I'm trying to think of an example. So last time I took Bailey into the ER, and I will admit I probably did this a little bit, not towards the nurse, but towards the doc. I was really angry that he wouldn't treat her the way I needed him to, and it took him 4 hours to decide to give her a bag of fluids, whatever, even though there's a standing order that they could have used. This would be like if when the nurse Crystal came in, I would be really angry with Crystal, and I'd be yelling at her, don't you think that doctor could do something? I wasn't, because I really love Crystal there, but so it's basically just transferring my anger towards the doctor to the nurse that was taking care of her, who did a very good job. Restitution, this is just undoing, reducing the feeling of guilt, making amends. Conversion reaction, basically this is when the anxiety and the stress goes from being a mental, it actually transfers into physical symptoms. And the symptoms can appear anything, and then once the stressor is reduced, these symptoms disappear. You guys have probably heard, I don't know if you guys have heard of it, maybe you have, a conversion disorder. Example, when Bailey was first sick, this is what they came up with all the time, because they didn't know what to diagnose her with. So they felt that her pulse rate, her dizziness, all of this, was that there was some stressor occurring, whether it was, they tried to see if I was abusing her, they tried to see if there was something going on at school or at home or whatever, that would cause her to be this stressed out so that she would have, all these symptoms. Turns out it wasn't. Avoidance. This is when our patients unconsciously stay away from something. It's exactly the way it sounds. So know those terms, and I'm going to actually see if I can find those videos quick. Maybe. If my computer will work. There we go. This is not it. That is not it. That is not it. Sorry guys, I had these up and then I... So this is the one on reaction formation, and it kind of really explains it well.
Angie's gonna be here soon.
Oh, I can't believe we're finally meeting your high school girlfriend.
I don't know what you guys are so excited about. A ton of people move to Chicago every day.
Penny, why are you talking out of the side of your mouth?
Why are you talking out of the front of your mouth, weirdo?
Wait a minute, Penn. Are you jealous because Angie dated Max before you did?
No.
Yes. Okay? I mean, she was the high school girlfriend. I'm the college girlfriend. It's a clash as old as the clash. I have to hate her.
Jane gets crazy competitive about my exes. Remember when she found out my high school girlfriend was a magician?
Oh,
Wait a minute. What is that behind your ear? Oh, my God. It's a quarter. Penny, you have a little something right in your... Oh, my God. It's another quarter. Again.
Guys, just promise me that when Angie gets here, you'll be cool. I mean, because when I dumped her, it was just messy and I hurt her.
Max, it's us. We're totally cool.
Yeah.
Okay, right. Dave, Don't put your hand out and then say, here's 5 good ones for you. Alex, do not tell her your theory about why the perfect murder weapon is a knife that absorbs blood.
But it is.
Brad, do not jump the gun on giving her a nickname too soon.
But I had angina locked and loaded.
And Jane, when she says to you, I've heard so much about you, do not respond with the classic, oh, I hope it's all good things. Oh, she's here.
Guys, I gotta warn you. I don't know how I'm gonna react to this, but it could get very ugly.
Guys, this is Angie.
Hi. Hi, girlfriend. Get in here, you. Look at you. It's so nice to meet you. You are cuter than cute, cuter than a button. Head to toe, you're a winner. You're a big star. I'm loving all of this. I did not know I was going to react like that.
Neither did we.
Get on over here. And join our gang of fun.
So see how she kind of totally went against what she was actually feeling? This one. So here's another video that I want you guys to see because it really kind of helps put things in order. Oh, this is not the one I wanted. I don't know if I saved it or what I did. I'll have to find it back if this isn't it. No, this isn't the one I wanted. Apparently I did not save it. Oh, what's this? I did post these videos for you guys to watch too.
Hi, everyone. Welcome back for another AP.
This is the other video that I really think explains a lot of them well. So, yeah, I want you guys to watch this one because it really. So I'll put it in here.
Psychology flip lesson. Today's lesson is all about defense mechanisms. These are things that you do to help protect yourself from the world around you. So maybe it's bad news, maybe it's a situation you don't know how to deal with, maybe it's a compliment that you don't know how to receive. In any case, Sigmund Freud came up with the original idea of defense mechanisms as different tools and strategies that you use to help protect yourself in cases of uncertainty. So when you don't know what to do, you pull one of these out of the toolbox. All of these are things that you've probably done at some point, and some of them we've talked about before, so those will just be review, and other ones, it will just be learning a term to associate with an action that you're already familiar with. So the first one that we're going to look at is denial. This one is very basic, the most basic of all of the defense mechanisms. With denial, you're just basically refusing to believe that whatever you heard exists or whatever happened at all. So protecting oneself from an unpleasant reality by refusing to perceive it. This is very common in cases of death of a loved one, where you hear that your grandmother died and you just keep on moving on like nothing ever happened. Or maybe you failed a test and you just pretend like that never happened. You don't think about it and it didn't happen at all. There's kind of a fine line between denial and repression, which is our next defense mechanism. Repression is one that we've talked about before. And this is where you're unconsciously preventing painful or dangerous thoughts from entering awareness. With repression, your mind is making a decision for you that says, I cannot remember this. Repression oftentimes gets used as an example in cases of child abuse or things like that, where it's just too painful for you to remember, trauma during childhood, where you are just forgetting it. It's not that you deny that it happens, although sometimes you might as well. But with this, it's painful, it's dangerous, you can't even pull it out of your awareness. It's underneath the surface of your consciousness. And it's just too painful for you to actually pull out, so you're not aware that it exists at all. Another defense mechanism that you probably have used before or seen before is displacement. If any of you work retail, I can almost guarantee that you have been the unfortunate recipient of displacement, which is where you substitute a different target for impulses when the original would be dangerous or unacceptable. So here's a scenario. You have someone that is at work and maybe they've gotten bad news from their boss. Maybe they're overworked. Maybe it's just not the place that they want to be. They're not fulfilled in their job. And then they go visit you at your store. Maybe you work at the apple orchard. Maybe you work at a grocery store. Maybe you work at a retail clothing store. And you're just the humble cashier or putting away things or just working on the floor. And they come to you and they just chew you out. They have displaced their anger. They've substituted you as the target of their aggression instead of their boss or, their spouse or whoever they're actually mad at. They can't actually duke it out with that person in the way they want to. So they chew out somebody else instead. This might also be the case, like with the picture on the left-hand side, where you're angry with something at school and you take it out on your little sibling. Poor kid there. That's another example of displacement, where you're substituting the target and putting it onto someone that's more vulnerable instead of the actual person that's causing you grief. Another defense mechanism is projection. This one happens all the time, but it's more subtle. So a projection screen takes something, an image, and puts it onto something else. So in the classroom, we have the projection screen that puts it onto the smart board. With projection as a defense mechanism, you have your own personal feelings, and these could be positive feelings, they could be interpretations of events, they could also be shortcomings or unacceptable urges or impulses, and you put those thoughts and images and whatever it might be on somebody else, and you think that they actually think that. So let's look at this example of this Valentine. So let's say that you have some feelings that have developed for somebody else. And you think about them all the time. This is like major 5th grade type crush. And all of a sudden, it's Valentine's Day, and they give Valentines to everybody. Everyone has their little Valentine's box. They're putting in all the Valentines, and you get your Valentine from that person, and you like cherish it, and you say, I know they picked up those words because they truly, truly love me. This is a match made in heaven. This is going to work. Now, your feeling is that you have this major crush on them, but you're attributing their actions as them having a major crush back on you, even though it might not actually happen. This doesn't just happen in this sort of scenario. Maybe let's say that you're really disappointed in your own performance on a certain sports team, and then you start talking about other people and you say, oh man, they're just so mad that the defense didn't come through, when really that's what you're mad about. So when you take your own feelings and you say that other people have them, that is projection. Another one that's a little bit tricky to understand is something called reaction formation. This is where you, as you see here, prevents dangerous impulses from being expressed in behavior by exaggerating opposite behavior. Essentially, you almost try to deny your actual feelings by acting out in the opposite fashion. So in this little cartoon here at the bottom, it says, hey Miranda, are we still on for tonight? Miranda here says, I'm totally sorry, I forgot, I already made other plans. And our original person here is really upset. She's thinking that she's mad, but instead of saying that she's mad, she acts out in the opposite fashion, reaction formation. She says, I'm not mad, I'm fine, I'm happy. I didn't want to hang out anyway, I'm busy, whatever it might be. You act out in the opposite way than what you're actually feeling. This happens quite a bit. Going back to our example of 5th grade style crush, think about boys and girls on the playground and how childhood crushes come out. This is a perfect example of reaction formation, where if two people like each other, sometimes the way that you can tell if they like each other is if they're like punching each other. So like if that boy punched you on the playground, that might mean that he actually likes you. You're acting out in the opposite fashion than how you actually feel, because you don't know how to deal with the actual feelings. Or if you're really upset with your mom and then you say like, man, I just really love you a lot. And you really try to focus on that. Maybe you're even trying to convince yourself. You're acting out in the opposite fashion than how you actually feel. Reaction formation. The next defense mechanism here is regression. And I've seen this sometimes, and I hear about it happening even more than that. So regression is whenever you get into a situation, maybe you don't know how to deal with it, but instead of acting and dealing with it as your actual age that you are, you retreat to an earlier level of development or to maybe an easier form of yourself. So the example I always think about with this is Imagine that you just got into a big fight with your parents, and right now you're 16, 17, 18. You're trying to demand respect as an adult, but yet I've heard of lots of cases, and I've seen some cases where you get in a fight with your parents, and instead of talking it through, like the young adults they know you are, people literally stomp off like a little child. I can imagine times, or I can remember times with my little sister where she would be in high school and she would run upstairs and slam her door. And that is a major form of regression. Or maybe it's when you go visit friends from childhood and all of a sudden you act like you're 10 again. These are both forms of regression. You don't know how to deal with that group of friends as, 17-year-olds. So instead, you go back and you act like you did when you were 8 or when you were 6. Another defense mechanism is rationalization. Rationalization is when you justify your behavior by giving reasonable and rational, but false reasons for the reasons that you're giving. Essentially, you're explaining away your behavior. Teachers see this all the time with paper due dates. It just happens. The day of the paper, everything breaks. It wasn't broken before, but all of a sudden now the printer's broken, the computer crashed, whatever it might be. Now, all those might be totally legitimate. They might be true. They might be reasonable. But that's not really why you can't have your assignment today. That's just the excuse that you're giving yourself. You're talking away the problem. The reason that you don't have it done is because you didn't prepare until the day before it was due, and then there was something that came up on top of it. But when you rationalize it, you're saying that the whole reason you didn't get it done is because the printer broke or the dog ate it or whatever your excuse might be. The next defense mechanism is sublimation. Sometimes we encounter things that really frustrate us really badly. It might be a fight with a friend. It might be being cut from a team. It might be a breakup with a significant other or some family problems. And sometimes it's just not appropriate to deal with it head on, or at least you don't think that it is. Maybe it's not appropriate to displace that either and take it out on a little sibling or, an employee on a store. If you use sublimation, you actually work off these unmet desires or unacceptable impulses, etc., in activities that are constructive. The perfect example of this is someone gets really angry and then they go running for like 5 miles. They're like, I just need to go deal with this. And they just go take off. And they work off all their angers. Instead of dealing head on head with whoever they're upset with or whatever the problem is, they decide to run instead. It's something different. Or maybe you write like angsty lyrics for a song that you want to sing. That would be another way of dealing with it in a different way. So you're not dealing with it head on and you're not taking it out on somebody else, but you're channeling your energy into something maybe more productive than a fight. The last one that I want to talk about is compensation. Compensation happens all the time. This is where you feel like you have some sort of weakness. It might be real, it might be imagined, and instead you focus on something else, or maybe you even focus on that particular thing even more because you feel deficient in that particular area. So let's say that you don't feel like you're a very good student. You know that school is not where you excel. Some people might take that feeling of inferiority and channel it, compensate it into really trying to excel in sports. Some psychologists are going to say you do that so people don't notice that you're weak at school. Or maybe it's the opposite. Maybe you're really bad at sports, so you say, I'm going to try really hard at school. On the other hand, one example here, especially with this little girl putting on lipstick, sometimes people just don't feel that attractive, and then instead of trying to go a different route, maybe they overcompensate with wearing way too much makeup, where you're like, you'd be really attractive just without makeup, but they feel inferior in that sort of aspect, so then they wear a lot more makeup to try to make up for that fact. So these are all different types of compensation, but you're trying to make up or counteract weaknesses that you may or may not have, but you feel like you do. Compensation. So in all, we've talked about several different defense mechanisms: denial, repression, displacement, projection.
I just like that video because it really gives you guys another viewpoint on some more examples to help you remember these. And like I said, know these definitions. Alright, so going into stress. Hans Selye termed stress in 1936. It's the response that the body does anytime there is a demand for change. His model, he named it the general adaptation syndrome, that GAS. And it's also called that fight or flight response. So what does the body do? There's three stages. The alarm stage, where the sympathetic nervous system jumps into alert. It wakes up the hypothalamus, the pituitary, and the adrenal medulla, and then they release stress hormones. The next stage is resistance. When the body adapts to a stressor, so maybe, like an example of this one is when you guys first started nursing school, you were probably in the alarm reaction part. Now that you guys are in second semester, your body has really kind of adapt to nursing school and the stressors, and kind of really have learned how to cope with the craziness of nursing school. And then the third stage is exhaustion. When the body isn't able to adapt and overcome the stressor, I'm not going to lie, you may see this come the time you guys get finished with nursing school. I know it sounds cliche, but I swear to God, it will be worth it when you guys are done, I promise. But these are the three stages of stress, and you will see all three of them in nursing school. I'm not going to go through all these. You guys can read them. Nonverbal communication, you guys are aware of these things. My big thing is remember that when you're saying one thing, make sure your body isn't saying another. So you might be standing there with your arms crossed and your foot out tapping, and you're like, okay, honey, I'm waiting. But in all honesty, it looks like you're saying, I'm getting really ticked off because you're not coming. So when you're working with people, make sure that your body isn't saying one thing and your words are saying another. Communication blocks, we will go over this a little bit. When you sit down third semester and actually sit and chat with your patients, sometimes sometimes what you say can actually just stop the conversation. You never want to change the subject. You let your patient lead the conversation. Don't give advice or approval or disapproval. Don't ever give false reassurance. So when things are really bad, make sure, it'll be fine. It'll be fine. Because sometimes it isn't fine, and then they will hold you to, well, you told me it would be okay. When you're talking with them, don't get focused on yourself. And I don't really like the one in here that says asking why questions, because if somebody tells you they're feeling really down and out and you don't ask why, there's a weird thing there. But just keep your conversations open. Mylu, you guys will hear this term in the psych unit, and it's a therapeutic environment that affects the behaviors. They will talk, like I said, the psych units have a therapeutic Mylu. There's containment, there's support, there's obviously structure, there's places for the patients to be involved, and their feelings are being validated. Psychopharmacology, just basically the use of meds to treat the psychological disorders. It's exactly what it sounds like. Psychotherapies, okay. Just different types of treatment that the psychologist can pick from. So basically the psychologist wants to reduce the emotional discomfort, increase the functioning, and increase better behaviors. So this leads us into CBT, cognitive behavioral therapy. I've actually seen this do wonders. I was kind of judgmental the first time I heard about it, but I've actually seen it do wonders. So this is really, I've seen it work. I've seen it done a lot with patients with personality disorders. So they feel like their experiences, their stressors are much worse than the average person. What CBT does, it actually teaches them to look at their situation and rethink it. So that way they aren't stuck on it for a long time. So your patient might see like the death of a loved one as a long-term depressive event. So say their father dies and they stay in this depressive state for 3 years. We all know that that's not a healthy length of coping or length of grief. So the therapist teaches that patient to view, yes, it's a very sad event, and you need to deal with it, and yes, you are entitled to being depressed, but it also teaches them how to deal with the sadness and make it a short-term, a healthy length of grieving time. I hope that makes sense. Counseling, it's just help and guidance from a healthcare professional. And if you're working as a mental health nurse, you might actually be the counselor. They do hire advanced practice nurses to be the actual counselors. But you may be having a one-on-one, sitting there chatting with your patient, and they need some help with some of the things they're thinking of. Group therapy, it's basically headed by a therapist. You guys will see the group therapy when you go to either Gunderson or I think Trumbull. I can't remember off the top of my head. Whitehall. But it's either a group of patients. It could be like Alcoholics Anonymous. It could be actually even family therapy, in-home family therapy. Mindfulness. This is a new, I guess it's not really new, but I haven't heard a lot about it up until a few years ago. And I have a hard time explaining it, but it's basically to get a person not to be focused on the past, not to be focused on the future, but be focused on the present moment. There is a video here that you guys can watch. And mindfulness is another thing that I was like, oh, whatever. But it actually does do amazing. My son had a counselor that he went to, and Monty was horrible at, oh, mindfulness, mindfulness, mindfulness. And I was like, okay, Monty, whatever. But when I saw my son when he was, well, he's 13 now, so he's probably 8, using it, I was like, whoa, that is really cool. So it's just a practice, mindfulness. Look up the video. There's just another stress talk, TED Talk on stress. So ECT. This is exactly what it sounds like, electroconvulsive therapy, where the doc is actually putting a person through a seizure to reprogram their brain. Not used for everybody. If the medications aren't working and these people are extremely depressed or catatonic, they may actually take them and have them do ECT. Electric currents pass through the brain, causing a grand mal seizure, and it causes the brain to produce and release serotonin, epinephrine, and dopamine. It's in like the recovery area of the operating room. The patient needs to sign an informed consent, just like any surgery. They're given meds to drive secretions, produce muscle relaxation so that their seizure isn't so much muscle and body, it's more brain. Their blood pressure is gonna be monitored, and the seizure needs to last at least 30 seconds, because they have an EEG hooked up. I think if I remember right, the doc I did it with wanted at least a minute. Side effects for the ECT: muscle soreness. Obviously, they're going into a seizure. They're going to be sore. Side effects are generally temporary, but one major side effect that I heard a lot of people complain of is they feel confused, like that day, and then they have really no memory. They forget things. So as a nurse, we need to make sure that they've been NPO for 4 hours before they have it. Make sure that they urinate. Make sure all their contacts, their hairpins, their dentures, all of that is off their body. And then after the ECT, we're going to monitor their blood pressure, their pulse as they come out of it. Nothing to eat until they have a gag reflex. And then we're going to document everything. This is another one I have a video on, but I have it right up here like I usually do. This is kind of one of those videos that are, like as you can see, torture or treatment. So they're kind of, I don't want to say biased, but kind of biased. Here you go, guys.
Depression is waking up in the morning and not wanting to face the day. It is a dark cloud that hangs over, that doesn't go away.
I just remember sitting in the chair, a feeling of hopelessness. I'm not going to pull myself out of this one.
I've literally had people tell me, I'm in hell. It's really bad, is it? No, Doc. I am literally in hell. I have died. I've gone to hell, and I'm being tortured.
It's just so unbelievably painful to watch your child do this, to suffer with this. I really questioned whether or not I would, if she had attempted suicide, if I would have called an ambulance.
They really tried basically everything that they had at the time. But medication just did not work for me at all.
That's when he brought up the subject of ECT.
There's no treatment in psychiatry that is more frightening than electroconvulsive therapy. It's putting electrodes on your head and shooting electricity into your brain.
Shock therapy? Really? I just didn't believe that he was actually suggesting that I have ECT.
I didn't think it was done anymore. I thought it was like lobotomies. You know, you just don't do it.
We had talked with doctors about the fact that if I got depressed again, we would consider ECT.
I was afraid to do this.
If something goes wrong, what happens?
The feeling of not knowing something you've never done before, about whether or not it will work, about whether you're going to have severe memory losses.
I worry about sort of losing this part of my mom, and that's really sad and scary.
Memory loss is absolutely the most feared and the most common side effect of electric shock treatment.
I couldn't remember phone numbers. I couldn't remember my boyfriend's name.
There are some long-term memory losses, and it is a trade-off.
I think that books and movies have unfairly shaped public perception on what electroconvulsive therapy is.
No doctor can tell me how it works in terms of the brain function. Nobody has been able to determine that. They do know in huge percentages of cases of severe depression that this is the only thing that works.
This is ultimately what we have to ask with electric shock. Is it a salvation that can get them out of that condition, or is it going to cause them to lose so many memories that it's robbing them of the sense of who they are?
I was desperate.
This is my only hope.
So, as you can see, it's pretty controversial. I've seen it do some amazing things for patients, and I've seen it do some terrible things to patients. I've seen patients who were functioning at a minimal level because of their depression. They went and had ECT and basically fried themselves. So it's half a dozen of one, 6 of the other, one of those types of things. Alright, so relaxation therapy. This is something that we can teach our patients on the floor, in the psych unit, wherever. Different types are breathing exercises, or progressive muscle relaxation where you start at the head and go all the way down to each muscle group, down to the feet. Soft music, guided imagery, where you teach a patient to imagine a really relaxing place to them, and then tell them to put themselves there. These can be used in OB during labor. So yeah, it's a good thing to have in your bag to teach. Alright, so now getting into actual disorders. Like I said before, stress is everywhere. Eustress is the positive stress. It causes anxiety, it causes stress, but it is that stuff that drives us. If we weren't stressed out about getting that paper in next week, we wouldn't do it. So phobias are another mental illness. There are so many different phobias. It's just the irrational fear of object or situation. So I have this first one, the coulrophobia, fear of clowns, somnophobia, people are afraid to fall asleep. My daughter has nomophobia, where she's afraid of being without phone coverage, I swear. Papaphobia, fear of the Pope. These are just some examples. Or trypophobia, fear of holes. And then the common ones that you guys might see is the agoraphobia, where you're afraid to come out into the public. Social phobia. This isn't the agoraphobia, where you're afraid to come out of your house or your area, but it's the fear of behaving or performing or doing something that might be embarrassing or humiliating, and it's really not that bad. Some people do not eat in public. Some people don't use the restroom in public for fear people might hear them peeing or doing the other, or people might not want to eat in public because they make themselves a slob. I don't eat ice cream cones in public because I get it all over my face because I'm a pig, but not because well, I guess it could be a little bit of social phobia. Panic disorder or panic attack. It's this fear, this nervousness that can't be controlled. These are the times when you see people come into the ER saying, "Oh, I've got chest pain," and it's really an anxiety attack. But they don't determine that until after they've done all the cardiac testing. So they have a feeling of impending doom. They're fearful. They may dissociate, nauseous, diaphoretic, chest pain, palpitations, shaking. All those are signs and symptoms of cardiac. So you can see where it kind of doubles over. Generalized anxiety disorder. People worry about everything. They might be restless. They might feel on edge, shaking, palpitations, dry mouth, nausea, vomiting. Easy frightening. They might be hypervigilant and watching everything going around them. These are all just pretty generalized symptoms. So, mild anxiety, everyday life. You're open-minded. You might be stressed, but maybe you're waiting. The example I hear is a job performance review, or maybe you're lost in a new city. Mild anxiety, like I said, the motivation that makes us do it, helps you find a solution. So if you are lost in a new place, you might look for a safe place to ask for directions. You've got mild anxiety, but you're able to function, and it actually helps you find a solution. Moderate anxiety, you're focusing exclusively on the stressful situation right in front of you. You're going to ignore everything else. Your brain is focused on this one task. So if you've taken a kid to the playground and lose sight of them, your heart's going to race. You maybe have dry mouth, sweating, stomach pain, nausea. Your speech might get more rapid, high-pitched, and once you find him playing with the other kids, your symptoms will subside. Example of this, if you can picture me at I don't know if you guys are ever aware of the Prairie du Chien Rendezvous. It's a rendezvous on one side and a flea market on the other. Lots and lots of people, like thousands of people. I had all my kids with me. I was pregnant with Ari. Lost my son. We had bought him sunglasses, and he looked up and was checking out his sunglasses and went left, and we all went right. And within seconds, there was so many people that flooded in that we lost sight of him. Obviously, my heart was pounding. I was sweating. I was gripping my stomach because I thought I was going to throw up, and my stomach hurt. And I'm, 8 months pregnant at this time. People actually thought I was going into labor right there in the middle of everything. But I couldn't do anything else except for worry about finding Gage. Kind of find out my little guy was smarter than I thought he was, and went and tried to find my dad. So, but you can't do anything other than what's right in front of you, what you need to do. So as nurses, we need to help these people identify the anxiety. We need to help them learn how to anticipate these anxiety-provoking situations. Let them talk, listen to them, be supportive with your nonverbal language, with your body language. Focus on our patient's concerns, and then clarify what they say. So you will say, "Oh, so you're telling me," and then repeat what they said. Encourage helping them learn how to problem solve. Help them find alternative solutions. Obviously, when the kid was lost, there was no other alternative solution. But explore behaviors that have worked in the past to decrease anxiety. And this is like in a test where some people wear earplugs, which I've seen do wonders, or sitting in a certain place, or whatever behaviors that work to help with the anxiety. So then that goes into severe anxiety. More pounding heartbeat, chest pain, anxiety, vomiting, diarrhea, trembling, scattered thoughts, erratic behavior, sense of dread. These are the times when you hear someone has been in a car accident, to lose your job unexpectedly. That's what severe anxiety is. You're not able to focus and solve problems, which leads to further anxiety. Sometimes you can't take care of your own needs. And a lot of times people trying to redirect your attention or distract you, that ain't going to work either. Panic level anxiety is most disruptive, most challenging. You're not able to function anymore. You might not be able to move. You might not be able to speak. Some run, some are fidgety and can't sit still. They're not able to think rationally at all. Their perceptions are distorted. Sometimes they have no safety awareness. They're not able to identify dangers. This is like major things such as being raped or being the victim of like a break-in or living through a disaster. So what do we do with these guys? We stay calm and we stay with them. We want to make sure that we are dealing with the environment and making sure that the stimulus is down. So if we see them, say, in the ER, don't leave the door open, don't leave the lights on bright, so we can, minimize the lights, pull the curtain, close the door, so that it's not craziness and the stimulus out there is not transferring to our patient in their room. Slow, steady voice, reinforce reality. Make sure we are taking care of their physical and their safety needs, because when they are panic level or severe anxiety, they don't have an awareness of this. They may since they don't know their safety needs, we might need to actually set limits to them. Allow them to maybe pace, because sometimes just pacing will kind of wear them out and calm them down a little bit. And if they do that, make sure we're offering them finger foods that they can carry with, because they're going to deplete their body of their calories. If all interventions fail, they may need to be medicated, or they may need to be put in seclusion. I want you guys to go through the medications for anxiety. There are different ones, the antidepressants and the I can't say that one. Anxiolytics. Just kind of have an idea. The SSRIs, the tricyclics, the MAOIs, and SNRIs, and then the benzos and the non-benzos. I do have that video that I posted. It's the one with the guy that I said, oh, that's not the one I wanted. But that will help you with the med portion of these. SSRIs, look through. You guys have kind of gotten this in pharm, but they do cause sexual dysfunction, can cause insomnia, anxiety, nervousness. Make sure you go through these. MAOIs are not used as much anymore because there are so many side effects. If they are taking an MAOI, make sure that they are not eating any foods high in tyramine. So like aged cheeses or smoked meats, chocolate, caffeine. Chinese restaurants have a lot of high tyramine foods because the tyramine will actually interact with the MAOI and cause a hypertensive crisis. So, tricyclics, these take a while to work. So, on to OCD, obsessive compulsive disorder. The obsessive portion of it is the repetitive thoughts, the urges, the images, the ideas, and the compulsion is the actual act of it. So if I'm always worried about germs and so that's always on my brain, I may wash my hands over and over and over. The activity that they do actually reduces anxiety. So maybe this person has a routine where they do this, they go lock their door, and then they go lay down. Well, when they lay down, they start thinking, oh, did I lock the door? They get back up, double check, make sure the door's locked, and then lay back down. So they may actually have to get up several times just to make sure that that door is locked, that they locked it, and that it is still locked. Or the person that washes their hands over and over, their hands can actually get raw and excoriated. You guys know how your hands get from washing them, like if you work in a nursing home or if you're a CNA. Imagine if you went home and washed and washed and washed and washed. PTSD. This is a disorder, an illness that develops because of an event. It's because of a trauma. Because of a trauma. There was a real life threat to the person's life or their health, and the patient was not able to do anything about it. So you'll see this a lot in veterans. You'll see it in rape victims, and you'll see it in people who have lived terrorist attacks. I mean, there's a whole lot of situations. So this is not just those three, but those are just some examples. A lot of patients with PTSD actually have survivor guilt. So if you have a veteran who was in a battle, their best friend was killed, and now they feel guilty because they survived. They may have lost both their legs, but they still survived. So they may have this feeling of guilt because they did survive, and there are other people that didn't. Flashbacks. These patients might actually relive the event in the moment. Sound, smells might actually trigger an event. I had a friend that we rendezvoused with, and we didn't even think about it. He was sitting around the campfire drinking, and Coon Valley let off fireworks. And it was a matter of seconds before he was up and gone. He literally thought he was back in Vietnam. We found him about a mile away, and he was hiding under, I don't know what the heck it was, but hiding under it, taking cover, and literally thought he was back in Vietnam. He thought that the fireworks that went off were actually bombs. So their flashbacks can be very, very, very real, and they aren't able to tell the difference. So their symptoms, flashbacks are dissociative reactions where they are in another reality. Maybe recurrent intrusive events or nightmares is a huge thing with the PTSD folks. They may become socially withdrawn. They may have changes in relationships. I know Doc's girlfriend at the time had a hard time dealing with it, and they eventually broke up. But it's hard for them to form this relationship. These folks might be hypervigilant. If you've ever seen somebody who came back from war, they're constantly aware of everything that is going around with them. They might be irritable, they might be depressed, and they might also have a chemical dependency. So they might be trying to self-medicate with alcohol or whatever it may be. So, major depression. The big thing here is it's depression that these symptoms actually interfere with daily life, with the social functions, with the occupational functions. Maybe they can't get out of bed in the morning, and so they're unable to go to work. People with major depression look at life through gray tinted glasses. They may have what's called anhedonia, so that they are not having pleasure in things that they usually enjoyed. And these folks may have suicidal thoughts and repetitive negative thoughts. So they may constantly think about suicide, or they may constantly think about how terrible they are. For a person to be diagnosed with major depression, there should be at least 5 symptoms. Could be weight loss, weight gain, increase or decrease in appetite. People are either sleeping too much or not enough. They're more fatigued, they're agitated, they're not able to think, they have feelings of guilt, they're indecisive, and they have suicidal ideation. So, that brings us up to bipolar disorder. Bipolar is a mood disorder. These patients will experience mania and depression, and they are on opposite ends of the spectrum. So when they're manic, they are extremely happy, extremely busy. They are go, 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 go. But when they are depressed, they stay depressed longer, and their depression is worse than the normal. These cycles may go slowly, so it may take months, or it might go rapidly, like days or even hours at times. So somebody who's manic, their moods are going to be excessively high. They're going to be very happy. They've got increased energy, activity. They don't need to sleep. When I've taken care of patients in the manic phase, I've had family come up and say they've slept 3 hours in the past 2 weeks. And these people are just go, 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 go. They're grandiose, so they think that they can save the world. Sometimes they might be extremely irritable, but they're very distractible. So if they're on one topic, and it's not hard to get them focused on another one. They show extremely poor judgment. I had a kid I went to school with. It was bikes and T-shirts or something like that, and he was going to save the world and save the children. But he spent his entire life savings on bikes and T-shirts. These folks are going to have a really rapid speech and a flight of ideas. So in a 5-minute conversation with them, you might talk about everything underneath the sun. They really, really involve themselves in pleasurable activities. They might be drinking. They might be engaging in sexual intercourse where when they are not manic, they are very safe. But if they become manic, maybe they're out having activities with 3 people in 2 days. And they might be kind of obnoxious and kind of intrusive. They just don't have a gauge of your space, my space type thing. I always said that if I had a mental illness, this is the one I would want because they can get so much done and they're so creative when they're in the manic stage. But they also do have hallucinations and delusions and those things, so that's not the fun part of it. Split mind is schizophrenia. It's thought and association with reality. Hard to determine what's a hallucination, what's a delusion, and these folks have a really limited socialization. I took care of a guy who would come in every morning to the psych unit, come smash our spiders because he really thought there were spiders crawling over the wall. He would take his cereal and then he would be on his way, but he would come and smash our spiders for us, and that was what he did to earn his cereal. So there's 4 phases of schizophrenia, and kind of you can see it progressing because that's how it works. The schizoid personality, where these patients are indifferent, they're cold, they're aloof. My cousin was diagnosed with schizophrenia, and now seeing these phases, I can really pick it out. So when we were kids, if we went over to his house, he would never be out in the living room or the kitchen, wherever we were for a holiday. He would always be in his room. So if we wanted to go see him, we needed to go sit with him in his room because he was just different. The prodromal phase, these folks are generally socially withdrawn. Their behavior may be different or eccentric. And you can see it in their communication, their thoughts, their ideations, and their perceptions. So, using my cousin still as an example, he's still, growing up, he was still very socially withdrawn. He did have a job and he was out on his own. He had like a 1-bedroom apartment that his mom helped him with. But he would do different things, like he would be out dancing in his front yard at 3 in the morning. And it wasn't because he just came from the bar. Just different things. So then it leads us up to schizophrenia, the active stage, where these psychotic symptoms are evident, and there's hallucinations, delusions, and it impairs their work and any of their social situations. So, my cousin passed away now, but when he had the active stage, he really tried to self-medicate, and it wasn't working, and he had gone to the bar and walked home and walked in his house, and he had all these voices, and he couldn't get them to go away. So he called his mom and he said, "Oh no, I told her everything," and the way he explained it makes so much sense. That it's like you're home by yourself, and you walk into your house, and you hear somebody screaming at you about how stupid you are. Well, you want to find that person, and you want to, kick them out of your house or whatever. So you search all through your house, and you can still hear them, but you can never find them. And then you'll hear more voices. So you can see where it would be very, very debilitating. So then once they get past the active stage, it may kind of fade into this residual phase, where it's kind of the same as the beginning of it. They're still withdrawn with a flat affect, and they have a lot of role impairment. So you can see the stages are very, very debilitating. Some of the positive symptoms, and if you remember, positive symptoms are in excess, hallucinations, illusions, delusions, and behavior and thinking are all disorganized. Negative symptoms, which is what's missing from their normal functioning. Their affect is blunted or flat. They have a lack of unprompted additional speech, so they're not working at continuing the conversation or adding to the conversation without being prompted. That's called alogia. Abolition. This is where they're not motivated to initiate and perform self-directed, purposeful activities. Might be, getting showered and getting ready for the day. But if you have 8 people yelling at you, it's really hard to concentrate and carry out these activities and stay focused on it. They might be apathetic, where they are not showing an interest in anything. They may have anhedonia, and again, social isolation. So this will get us into personality disorders. And there are 10 different ones, basically, and they're all grouped according to their symptoms. But in here, I just added 2 of probably the most common ones, I guess. So borderline personality disorder, these people are going to show a pattern of unstable relationships, unstable self-image, their affect is going to be unstable, and they're going to be really, really impulsive. They're scared of being abandoned, they're paranoid, and they may have dissociative symptoms. When I worked with borderline personality disorders, I saw a lot of staff splitting, so that they are making one person sound wonderful and devaluing the others. So like one nurse they held in high regard, and the rest were a disappointment. Example of this, when I was orientating, I saw one person with bipolar or borderline personality disorder being brought into the unit, and as she passed the nurse that I was with, she literally just about jumped out of the wheelchair and says, "I can't make it without you, Anna. The rest of these people just irritate me." So they really focus on one person. You may see self-mutilation, suicidal behaviors, activities, gestures, and threats are common with these. The antisocial personality disorder, these people have a disregard for the rights of others. They don't show empathy, they don't show remorse, there might be criminal charges, they're impulsive, they're reckless, they're irresponsible, deceitful, and these are the ones that are out there committing crimes, whether it's as serious as murder, but this is what you'll see. There's a lot of the antisocials at Mendota. This goes on to addictive disorders, substance abuse, addiction, compulsive use of a substance that will continue despite negative consequences. You see that a lot in alcoholics. Tolerance, so the more they use, the more they need to obtain the same effect. So if you're drinking 1 glass a day for I'm just going to make it short term, 2 weeks. At the end of that 2 weeks, you need 2 glasses a day to equal what you were feeling after 1, and it just gradually goes up and up and up. Physical withdrawal symptoms. This is what happens when the body is no longer given that substance. You'll see this in like the neonatal abstinence syndrome, or when somebody stops drinking or using opioids, but their body actually, the response to not having that substance in their body anymore. Family members might actually be codependent or enable the user. Example, trying to think of a patient we just recently cared for. He was drinking quite a large amount every day, and the mother would actually stop on her way home from work, and I mean, he was of age, he was just staying with mom, and pick him up his alcohol of choice, so that he always had a supply, because she didn't want to see him sick. Alcohol abuse, we kind of went over this. These are just the people that are having binges that last 2 or more days. They might be blacking out, vomiting, at risk for dehydration. Kind of generalized stuff. So when somebody's been drinking a long time, and they quit, they actually will, it's called detoxing. Their pulse and their blood pressure elevate. They might be hallucinating. There is a CWA scale, and I know some of the students that I just had on clinical were able to complete that. They might feel like the creepy crawlies, they get a headache, nausea. So these are all just the body detoxing from the alcohol. Well, if the detoxes are not treated appropriately with Ativan, or what, if there's another, whatever the other, I can never remember the other med that they use. The body can actually go into what's called delirium tremens. The neurotransmitters are no longer suppressed, so these people are really seeing visual hallucinations. They're going to be extreme tremors. So like in detoxing, they'll be shaking, and you can see it with their hands, or you feel it, the tips of their fingers or their tongue. If they stick their tongue out, you can see it better. But they're really going to be shaking. Like, they're not even going to be able to do purposeful movement. Like, they can't sit up and pick a glass off the counter and take a drink. And then it can actually lead into grand mal seizures. So, yeah, it can be very serious. You guys know the substance abuse symptoms. Red watery eyes, runny nose, hostile behaviors, paranoia, needle tracks. Another, with meth, you're going to see these people, they're going to be sweating because meth actually increases the body temperature. Their pupils might be blown. They might have like what almost appears as tics. Irritability. Yeah, so it kind of really depends on whatever substance is being used. Suicide. So when we have somebody that has actively stated that they want to commit suicide, we need to be really in tune to a lot of things. So subjective data, what are their verbal clues, what are their nonverbal clues, what are their comments regarding suicide. So when they're talking about their plan, as a nurse, we need to always be thinking, okay, is there a plan? Yes, they may have a plan. Is this plan lethal? Well, it depends on, are they taking 30 Vicodins or are they taking 30 stool softeners? Well, the Vicodins are going to be a lot more lethal than the stool softeners. Does the person have means to access this plan? So if this person's plan is to take 30 Vicodins, but they have no way of getting 30 Vicodins, the plan is not as, yes, it's still very important to investigate, but the plan is not as pressing or as urgent as if they would have access to the 30 Vicodins. And then one other thing is that has their mood changed? Did they go from being extremely flat and depressed, so now do they seem a little bit happier because maybe they're thinking a little. So then we also need to be looking at objective data. Do they have lacerations like on their wrists or on their arms? Do they have previous scars or scratches that might actually be from a previous attempt? You know, what can we see when we're assessing them? I really feel like there's just a lot of stuff in here. Oh, we're almost done. I didn't think we were that close. No, I lost where we were. So crisis management. There's different types of crises. So like a maturational crisis, this occurs during normal development. You know, maybe the teenager is dealing with peer pressure or those types of things. Situational crisis, that's an external source of stress, but most people encounter it at one point in their life. Might be the death of a loved one or the loss of a job or something like that, where it's situational, it's short-lived, and at one time or another, most people will encounter something to this degree. So then adventitious crisis, this is a disaster. This is not something that everybody deals with at one point in their life. It's not planned. It could be a natural disaster, such as like when we had the floods up here. It could be like a national disaster. Could be a violent crime. So you see where not that it does happen, but not everybody has to deal with it at one point or another. For the adventitious, situational. It's external source of stress, but we go through it at one point or another in our lives. And then maturational is just the normal, happens during normal development. So this goes back into, I don't know why this does this, but anyways, goes back into situational crisis. External again, unanticipated. I don't know why I have a double on here. Sorry guys. Job loss, love loan, job change. So these really depend on how a person copes with it, the kind of support they have, whether it's going to go into this huge crisis mode or not. Nursing goals with this, client safety, whether they're suicidal or homicidal, because that's always our number one goal, and then to help reduce the anxiety. I know that when I was helping people clean up with the flood, you just saw people, I mean, they were just doing it at this point, but they would take a break and they would look at all their things on their lawn and just start tearing up. It was terrible. That was terrible. People were losing stuff that they had saved for months. One lady that I really felt bad for was her daughter had passed away, I don't know, probably 6 months before, and she had kept her daughter's room exactly the way it was. I mean, she made the bed, but otherwise she had all of her daughter's trinkets and all of that type of things exactly where her daughter had left them in her bedroom. The flood came and wiped out all of it, and she ended up throwing all of it. And I literally was trying to help clean up some of the stuff, and she just sat down and bawled. So I can see where that would go into the situational or the adventitious crisis. And then our last slide, the autism spectrum disorder. Brain's developed abnormally and it functions abnormally. If you guys have dealt with kids with autism, they really have a deficit when it comes to social communication or interaction. A lot of autistic kids won't even look at somebody in the eye. They have very repetitive behaviors, interests, activities, so they do the same thing because it comforts them. They don't really understand emotions. They really need help understanding that other people have feelings. Anytime the routine or the environment is changed, they can actually become very upset because they're so sensitive to change. And like I said, they may not have eye contact. And there is a lot of disorders on the spectrum. It doesn't just it's not just straight autism. It can be a lot of things. I know my son has mood dysregulation disorder, which is on the autism spectrum disorder. So he has some of these signs and some of the same signs as autism, but he also can understand that there are other people have feelings, and he doesn't have an issue with looking people in the eye. So he's got some of these symptoms to a degree, but he doesn't have all of them. So just know that there's a huge, that's why it's called the spectrum. But I hope this helps, and I hope you guys are all done shoveling all that crap out there. I went out and did 4 driveways before I came in to record this. Yeah, I live in a very old neighborhood, so I had the 83-year-old neighbor trying to shovel his driveway. Well, actually, he had the driveway done before I could get over there because I had to go to my mom's. But I really hope you guys are done shoveling because that was a pain in the neck. If you guys have any other questions when you're listening to this, let me know. I will do a review, probably, I don't know, Monday, probably, so that you guys are all caught up with that and get that posted. I think that's about everything. So get a hold of me if you need anything. All right, thanks, guys. Have a good one.